Thank you so much, Dr. Isaacs, for joining us this evening.
Thank you so much for having me.
So, Dr. Isaacs, why don't we start by having you just share a little bit about what was most interesting to you in San Antonio. There was quite a bit of data reported for people with metastatic hormone receptor positive, HER2 negative breast cancer. So why don't we start there about what was most interesting to you?
There were a lot of new drugs and new findings presented at San Antonio, and a lot of them, as you mentioned, focused on hormone receptor positive, HER2 negative breast cancer. And that's just, it's not that there aren't other things going on in other subtypes of metastatic breast cancer, just that was sort of the majority of new presentations were on that. There are a lot of new drugs out there, so people are trying and to really develop some alternates to or some additional types of agents. So there's this whole class of drugs known as oral SERDs. They're similar to a drug that has been around for quite a while, a drug called Faslodex or fulvestrant, which is an injection. That's a very effective therapy that we've had around for a long time, and companies have been developing oral versions of it. So there are a number of trials presented about some of these oral SERDs. And there is one in particular that has sort of made it out in front of the rest of the pack, although there are a lot of them following behind that compared it to Faslodex, which is that injection, which is it's painful and it's inconvenient. And so we all want to find better ways of giving effective therapies. And so that trial presented their data in women who'd received prior therapy, second line or beyond therapy, who'd received a class of drugs known as CDK4/6 inhibitors, and showed that it was really effective in that setting as well, particularly for women who'd been on the CDK4/6 inhibitor for a while. So those were very encouraging findings, as well as some of the other drugs in that class were presented. That also looked like they have some exciting data. And then a whole new class of endocrine or hormonal therapies known as PROTACs. They actually are a new way of degrading or breaking down proteins. And so what this drug does is, in a different way, it breaks down the estrogen receptor. And the estrogen receptor is sort of the antenna, it's like the old style television antennas. For those of you who are old enough to remember old style television antennas, they're sitting there waiting to receive a signal. So the estrogen receptor is like the antenna. And when estrogen comes around and it hits that signal, it turns it on. And basically what we want to do is not let that happen. We want it to be turned off. So this new class of drugs basically gets rid of the antenna, degrades the antenna in a different way than other drugs have. So that's a drug that we'll see moving forward as well. So those were some of them, but there were a lot of other interesting presentations. There were some updates on another new class of drugs that has really come on the scene, what's known as antibody drug conjugates, which are it's a chemotherapy, but that's attached very firmly to an antibody. So it uses the antibody to hone in on the cancer cell, to be taken into the cancer cell and released just locally into the cancer cell. And the thought on that is that you'll minimize side effects from the chemotherapy just floating around in the bloodstream. So it gets into the cancer cell and has its activity there. So there's a drug, Trodelvy, where they presented some updated data in the hormone receptor positive space as well. But that's a drug that's actually a new drug for us also in metastatic triple negative breast cancer. So it's encouraging to see its activity in different types of metastatic disease.
Thanks so much for that overview. So much information there, and we're already getting follow-up questions to some of what you talked about. A question that I was hearing from some folks on site at San Antonio was whether the side effect profile of the oral SERDs does it look any different than the side effect profile for fulvestrant?
Yeah, they do. So there is they have some different side effects. So elacestrant, then they don't yet have a cute name. So it's hard for us to pronounce, let alone for everyone else to pronounce. You have to say it about 15 times before you can say it properly. But that drug has a little bit more in terms of GI toxicity, unfortunately. I mean, the fulvestrant itself is typically quite a well-tolerated medication. I tell people literally it's a pain in the butt, because that's really what it is. It's 2 shots, monthly, and those are uncomfortable things to go through, and they tie people to infusion units. So obviously what we want to be able to do is to let people live their lives and go about. And now that we're actually getting back out in the world post-COVID, being able to travel and get places, not be tied down to infusion units like that. So it does have a little bit more in terms of toxicity. Some of them have a little bit of visual stuff going on, although it looks like in the studies that were presented, it was less than we saw in the very early studies. So that was encouraging. But they do seem to have a different side effect profile than fulvestrant. So they have the convenience of oral administration, but some people have a little nausea with it. Some people have some diarrhea. So there are some different side effects that we're seeing.
Thanks for answering that, because it does seem like there are a number of these medications that are coming through, and we may start seeing them in the clinic in the next year or so. Yeah. You also talked a little bit about trastuzumab deruxtecan, or Enhertu, and there are a few questions already about whether there were any new reports about HER2 low. Mm-hmm. Breast cancers, which I don't recall seeing any, but there was a whole session in the afternoon that was talking about how to test for HER2 low. So it seemed like there was a lot of conversation about how to identify who might be able to take this medication. Can you tell us a little bit more about what you're seeing and what you're experiencing?
Absolutely. I think that's a really important question that we're all trying to sort out as well. So HER2 up until a few years ago was HER2 positive, and HER2 negative was anything that wasn't HER2 positive. And I think for anyone who's seen, a pathology report and seen the HER2 results, it actually comes out in a sort of confusing fashion. It comes out what we had called HER2 positive was by looking at the intensity of staining for HER2 on the cancer cells. And positive was either HER2 3+, okay, or what's called FISH amplified, which is a separate test, which they typically do only if it's HER2 2+, because some of those can be HER2, really have HER2 in excess amounts. But before that, we used to ignore the HER2 1+s and 2+s, and those all fell into the HER2 negatives, the HER2 2+s that were FISH non-amplified. And more recently, there's been a great deal of interest in looking at HER2 low, because there are some drugs that target HER2, some of those antibody drug conjugates, the one that I was talking about beforehand, the Trodelvy, which is an antibody drug conjugate. And so there are some antibody drug conjugates where the antibody is actually looking for HER2. And what it's doing, it's trastuzumab in some ways that's looking for HER2. And what we've recognized is that it appears to be able to locate it and do damage, even if it's not traditionally HER2 positive. So if the staining on the tumor was HER2 1+ or 2+, then we now have data from a trial that was not presented at San Antonio, was presented at ASCO a few months ago, where they showed significant activity of that drug in tumors that were HER2 low. And this was looking both in the hormone receptor positive HER2 low and in the hormone receptor negative HER2 low, which previously we just called triple negative. And because everything that was HER2 1+, 2+, or 0 classified as HER2 low. So it's a really, really active drug. And it's what we know when we have a drug that has a specific target, it's really important for us to be able to accurately measure the target. And so there's been a lot of discussion, what's the difference between HER2 0, HER2 1+, HER2 2+, where do you draw the line, and how consistent is it across different pathologists? And there's a lot of focus on being able to make sure that we are, as a medical community, properly assessing the tumors and properly determining whether somebody would be a candidate for this drug. There also, as an aside on that, there's also a great deal of interest. So we've shown that this drug Enhertu works in HER2 positive disease, but we've shown that it works in HER2 low. But there's interest in saying, well, might it work even if it's super duper low, like the ultra lows? So there's some studies ongoing to look whether it might be active in things that previously have been called HER2 0, maybe there's actually some activity even in people who have tumors that have HER2 ultra low. So I think we don't know how far down we're getting that boundary for that class of drugs. And there are other drugs that are coming down that are also looking at that space in terms of the HER2 low space.
Thanks, Dr. Isaacs. So actually, while you were talking, I saw a question pop up in the chat. Could you clarify? So this person was asking, is triple negative breast cancer now considered HER2 low? Could you talk a little bit about sort of how doctors are thinking about this and how they're approaching the idea of triple negative breast cancer and HER2?
So maybe I can step back even a step back from that and sort of go back to what we had talked about for now, a couple of decades up until about a year and a half ago or a year ago. Okay. So traditionally, we divided breast cancer into different subtypes based on the presence or absence of certain receptors in the cancer cells. So we had estrogen receptor, progesterone receptor, and HER2. And these are all like these antennae that are sticking up there. They're these proteins that are sitting either on the cell surface or within the cell that are waiting for a signal to turn them on. And basically, we don't want them to be turned on. We want them to be turned off because when they're on, they drive the cancer cell growth. Okay. So we used to divide tumors into hormone receptor positive, which was either estrogen receptor positive or progesterone receptor positive. And then or HER2 positive or HER2 negative. And HER2 positive was either that it was HER2 was present in a very high amount. Either it was called IHC, which is immunohistochemistry, meaning that the cell stained really brightly. Okay, it's actually a brown stain, so it's not really bright, but stained very uniformly and very significantly, 3+, or that when they looked for the gene that codes for that protein, that it was present in excess amounts. And that's what amplified means. Okay, so we were really left with, tumors that were negative for estrogen receptor, progesterone receptor, and HER2 by the standard way, and those were called triple negative. We have hormone receptor positive and HER2 negative, and then we had hormone receptor positive and HER2 positive. And that's what we had, and that was sort of how we approached the treatment of breast cancer prior to the advent of these drugs that looked at HER2 low. So the HER2 positive stays HER2 positive, and HER2 positive can also be, there's one more class that I didn't tell you, there's hormone receptor negative, and HER2 positive can also exist. So the HER2 positives are still HER2 positive, and we really look at treatment there that is geared towards the HER2 positivity. Okay. But now what's happened for both what used to be hormone receptor positive, HER2 negative, and triple negative, which is really hormone receptor negative and HER2 negative, we've now exploded out that HER2 negative group. And we're now dividing it. We're saying, okay, negative is not clear enough for us anymore. We need to see, is there any HER2 at all present on this? Because now we have a drug that targets that, and that's effective for that. So that's why we need to know that. So we've divided those classes out now into the HER2 low, and then the ones that are really HER2 negative, which is HER2 zero. So we've gotten two more classes, and we've broken, those groups into those different categories. And for the time being, at least, we consider that somebody has a tumor that is HER2 low if on any biopsy there was some HER2 staining. Okay, it doesn't have to be the last biopsy. It could have been the first biopsy or any biopsy in between. So any time that the tumor stained positive, 1+ or 2+, and didn't have the excess amount of protein, so was FISH negative. And I know we're getting really technical, but I don't know how to do this without getting technical. So I'm sorry if I'm confusing all of you. I'm not trying to, but it is sort of that is how we break things up. And now we have to break that up because we have this effective therapy that we need to think about whether we give. And the other class that we break out as an entirely separate class are women who have genetic mutations or genetic predisposition to breast cancer, who have either a BRCA1 or a BRCA2 mutation, or maybe a PALB2 mutation, because we also have specific therapy. So now it's important to know a lot of different things so you can be sure, I can be sure as a clinician, and you can be sure as a patient that we are thinking of the right treatment for the tumor that somebody has been diagnosed with. And now that we have these new therapies, we need to know all these things.
Thank you so much for explaining that, Dr. Isaacs. And we do know this is extremely confusing. It's a lot of information. And at LBBC, we're working on updating our content to explain more about what HER2-low is and how we test for it. So please look for that in the coming weeks on lbbc.org, and it will help reinforce some of the things that Dr. Isaacs just explained. We have a participant who is on Enhertu right now and is finding the side effects to be difficult, and is asking whether it may be possible over time that the side effects could become less, or that if there were a different dosage, it might be easier to take.
So there are certainly side effects from these new drugs. So Enhertu is a drug that has a potential to have some nausea with it and some GI toxicities. It can have some fatigue with it, and a number of other things, including very rarely causing some damage to the lungs, which is something that we're really very careful for and very vigilant about. We often find that over time, there are two things that I want to answer with respect to that question. One is, over time, hopefully you and your doctor and healthcare team is able to work together to try and figure out how to manage the symptoms in you. We always, we tend to try and start with something that we think is appropriate in general to try and minimize symptoms, but everyone is different. And you never know how one person is going to experience a drug versus another. So usually, once you see how somebody's gone through the first cycle, you can work with them to adjust the anti-nausea medication, or somebody's not having nausea at all, but the Zofran is giving them constipation. So you want to bring it down. So you really need to adjust like that. So over time, there is certainly that potential to address and to try and mitigate side effects. We also, often dose reduce. And we often have to dose reduce because, again, what we're trying to do is, we want to try and help people live the best lives that they can live. And by giving medications that gives a ton of side effects, that's a problem. And that's something that we don't want to do as clinicians either. So we want to make sure that people tell us how they're doing, tell us how they're managing, so we can help to try and deal with those side effects and try and figure out how we can manage them and diminish the side effects as much as possible. But we often dose reduce drugs. And there's this whole movement at the FDA, very appropriately, to try and figure out what's the right dosing of drugs. The way that we have traditionally dosed drugs and the way that we've done drug development as a medical community is that we've gone to what we call the maximum tolerated dose, the dose at which the side effects are acceptable, but they might be significant still. And we'd love to figure out what is the biological dose, like what dose do we need to go to, the lowest dose that we can go to for it to be effective. And I think the FDA is really starting to turn in that way. They're actually requiring it for all new drugs to really focus on the dose, the lowest dose that can be effective, as opposed to the highest dose that people can manage. And sometimes there's a big window between that. Sometimes there's not. But for different drugs, we really want to look at that. But I know there was a terrific presentation. The years are blending, particularly with COVID, but there was a fantastic presentation that was done by a patient advocate group that in, very short time sort of got feedback about, what patients wanted and how they'd want to talk about dose reductions. And I think, we heard that and we know that, but there was also then in follow-up a survey of doctors, and doctors say they're happy to dose reduce. So it was good to see that most doctors were also happy and interested in reducing doses, because we really do want to be giving effective treatments, but giving them with the minimal amount of side effects as possible.
Dr. Isaacs, when a person gets a reduced dose, can they feel confident that the medication will work as well?
I can't answer that in a blanket way. We know for some drugs, yes. For many of the CDK4/6 inhibitors, we know that lots and lots of people had dose reductions, and there was no difference in the efficacy in women who were dose reduced versus not. We know that in the real world, we do a lot of dose reductions, and we see efficacy. We see that the drug is beneficial. But it's hard to say. There are some drugs where probably we're not. So there are some of the drugs where we know you can decrease a little bit, but if you decrease a little bit more, you're below the dose where it's effective. But I think for many drugs, we think that we can reduce the dose at least some and still have efficacy.
Great. Thank you for answering that question. So I'm going to jump into some of our participant questions, as we have quite a few of them. And I'm also going to ask a few that we got in advance. So hopefully we'll get to as many questions as we can. One of our participants is asking about targeted therapies in triple negative breast cancer and what is sort of on the horizon for those, which ones exist, particularly after cancer growth from other types of treatments.
So as I mentioned, we're already starting to break triple negative breast cancer into different categories. And we recognize that traditionally it had been defined by what it didn't have, but not what could be targeted. So we know that we treat triple negative breast cancer that is PD-L1 positive with immunotherapy. There's a lot of interest. Excuse me, there's a subset of triple negative breast cancer where there's positivity for the androgen receptor. So there are studies that are ongoing or about to launch looking at targeting the androgen receptor in these triple negative breast cancers. They're the antibody drug conjugates that are being looked at. And those are really, I think, the wave of the future when we think about chemotherapy, because what they're, excuse me, more targeted ways of delivering chemotherapy. So sacituzumab Trodelvy is a drug that targets a protein that's expressed on many triple negative breast cancer. So it hones in, finds the cancer cell and gets internalized in the cancer cell and releases the chemotherapy there. So there is a lot of interest in these antibody drug conjugates and looking at different proteins that are expressed within different cancers. So there's a lot that's going on. And then there's a lot to try and augment the benefit of immunotherapy, to try and use other immunotherapy drugs or try and use other types of chemotherapy to potentiate the immunotherapy. So there's a lot going on there.
Great. Thank you for answering that, Dr. Isaacs. Please take a sip of water. So I'm going to ask a couple of really excellent questions that we got ahead of time. So the first question is, can you explain why I have to wait to take a drug that's been shown to be successful, but only after I've experienced a progression on one or more treatments?
So the answer to that, that's a great question to start with. And drugs are approved and studied in sequential ways in medicine. And, a lot of us are trying to figure out whether we could upend a little bit of that as well. Okay. But when drugs are studied, let's take Trodelvy. Trodelvy was studied in women who had received at least 2 prior chemotherapies and no more than 5. So that's where it's approved, because that's where it's shown its benefit. There are studies ongoing to look at it earlier on, but the place where it was shown to be effective was in that particular setting. And that's how the FDA approves the drug. They approve the drug typically based on the setting in which they were studied. And there are often, some subtleties to that. So it depends. It doesn't mean that everyone has to wait until that point. It depends how quickly the disease has progressed or what's going on. And sometimes we can get it approved for an earlier on setting, and sometimes there are ways to get around it. But that's really how drug development has been done. There is a rationale behind it. And, one also wouldn't want to upend a drug that really does well in the first line setting just because we think we have something that might work better, because we're wrong sometimes, right? Studies are negative, and we've seen that over and over again. So there is a rationale behind it. It is frustrating when there's this really exciting drug that one has to wait for it. But, the good news is that for other drugs, things didn't push out things that were available to us earlier on. So, that is a problem that we encounter, and we encounter that even more so when we're thinking about, why couldn't we use some of these drugs in the earlier stage setting where we might be able to cure more people. And again, the natural progression is to look at it this way and then move it into earlier studies. So there are studies, for instance, with Enhertu, the drug that we've talked about, that are now, a lot of studies are underway looking at the first line setting. We saw at San Antonio the first study that we saw about Enhertu in HER2 positive disease was in the second line setting. But there was another study coming that actually had been designed first that was looking at the third line setting and showed a benefit. And that was presented at San Antonio. So showing us this drug is active at all sorts of different phases. And I think some of the relief that I take and I think is present is I was happy to see the results of the trial in third line setting for Enhertu for HER2 positive. There was a survival benefit seen. So that meant for everyone who'd already gotten their first or second or third line therapy, even getting it later on still provided significant benefit. And so that was a reassuring finding when we look at things and try and think about how we recommend drugs in different settings.
Thank you. Thanks for addressing that. And another sort of related question from someone is would an initial treatment after a recurrence be any different if the recurrence was a very late recurrence versus if it was very soon after an early stage breast cancer diagnosis?
So again, that's a great question. The answer is yes. If somebody has a recurrence long after completing other therapy, then those therapies that we used way back when, we could think about reusing them, or it could say something about the behavior of the tumor. So yes, we very much factor that in terms of determining what we think is the best treatment. I think I did this with you, I think, a number of years ago, and it's hard. What I say today will be wrong in about 2 months, which is fantastic, because that means we have all these new agents that are coming and are available to us and that we can use and that are effective. It's a lot harder to answer these questions because it's so nuanced and so individual. And it's harder to sort of wrap your head around it and to say exactly what you're going to do and what we would do in what situation. But the underlying reason for that is fantastic, because we have all these new treatments and we're getting better and better at treating the specific type of tumor that somebody has, and not just this huge, group of people that we're just putting all together. But it does make it makes it harder to transmit messages because the messages are so unique and so changing.
Definitely. So I'm going to ask this question now. How important is it to get a new biopsy before changing treatments? And how can that be done if you have bone-only mets?
Okay, so again, another great question. So I don't think it's important to get a biopsy every time. Okay, so that there's a need for change of treatment. But it is really important these days to get a biopsy, okay, and to make sure that it's sent off and it has this, what we call next generation sequencing or molecular profiling done on it. It's a process that takes a little while. It takes a few weeks typically to get the result back, but we get sort of a comprehensive portrait of the proteins or genes that are turned on or have changes in them, and it really helps to guide the treatment recommendations because there are therapies out there. And then the other thing to think of is to think about a clinical trial and to look for a clinical trial if there is a change in the tumor. So it is important to get those biopsies, certainly at the time of diagnosis. For the vast majority of people we're doing it. It didn't used to be universally done. I'll tell you, at most academic centers, we've been doing it for 25 years or more. I think it's become very mainstream now to do that, to make sure that what are the characteristics of the tumor? We recognized a number of years ago that hormone receptor and HER2 status could change, but now we have so many other things that we need to be looking at. So it is really important. In terms of the bone, There are different ways to look at the molecular profile of the tumor. So the traditional way is to get a biopsy and to get tissue, but we now have abilities to detect circulating tumor DNA. So sometimes you can get what's called a liquid biopsy, which is from a blood test. They can do molecular profiling and see if there's any circulating tumor DNA or circulating tumor cells or other things that they can look at, and they can see whether the tumor has mutations or changes within it that they can detect in the circulation. So there are different ways to do that. So sometimes for women, particularly women with bone-only disease, that's something we think of. But honestly, we obviously want to think about it in everyone because, it's much nicer to have a blood test than to have a biopsy. The issue with biopsying the bone is that for the pathologist to be able to really get at that specimen, they have to get rid of the bone. They slice the tumor, okay? They take it, they put it in basically in like wax, and then it gets sliced into very thin slices, and that's when they look at different things on the tumor. But if it's in bone and there's bone around it, they can't do that. So they have to use a system to get rid of the bony tissue, and that can change the tumor tissues that's there. So you could get false negatives because in getting rid of the bone, they can get rid of some of the proteins that might have been there on the tumor. So one just has to be careful if it comes back negative. You don't particularly for hormone receptors or HER2 done by certain methods, it could be a false negative is what we need to know. If something comes back and it's present, well, we know it's present, but the fact that it's absent, it could have just been the method that they had to use that made it appear to be falsely negative. But there is a lot that we could still get for bone, and we do sometimes do that, and we sometimes get some interesting, some very helpful information from it. It's just that we prefer to get a site where we don't have to worry about the accuracy of the result.
Thank you. That's very helpful. There's a question about circulating tumor DNA or ctDNA testing. Is this currently recommended in general for metastatic disease surveillance?
So the answer is in December 2022 for breast cancer, no. Again, that is something that we are all looking at, and there are a lot of studies looking at ctDNA. There are lots of different ways to look at it to see whether decreases in ctDNA, how quickly it decreases. Would that mean something? Does that mean that the treatment is working? Or if it's not going down quickly enough, should we do something about it? So there's all sorts of things that are being looked at in terms of ctDNA. We're thinking about it for surveillance or for suggestions for early recurrence or something like that. But there are not solid data in breast cancer right now to be using it as standard of care. So I personally would not recommend it for standard of care. I think that it's something that needs to be done within the setting of a study so that we can better understand things and understand how to interpret the results.
Thank you for answering that. What are your thoughts about new diagnostic tools such as FES PET scans and using them to look at the hormone receptor uptake?
So that is a technique that I think is going to be incredibly useful, okay? Because one of the things that we're trying to, again, think about and try and increasingly do is be personalized and individualized in our therapy. So the FES PET, and then there are variations of it as well, is a way of actually seeing whether the tumor lights up because there's estrogen receptor present there, okay? So it's a way of telling us that the tumor might continue to be responsive to endocrine therapy or to hormonal therapy. And there's actually a variation on that where they actually look at whether they give a dose of estrogen and see if there's a change. And that actually suggests that the tumor is still responsive to endocrine therapy. So there are all sorts of things coming down the line for that. And I see that as a place where we're really going to have a lot of new developments in that area as well that will help us figure out whether somebody's tumor is likely to respond to a particular therapy and help us, what we're trying to do and what we want to be is increasingly individualized, because not only do we, of course, want to treat somebody who's going to get a benefit from a therapy, But we also don't want to treat somebody who's not and just going to have the side effects. So there are two sides of that are really, really important for us.
Great, thank you. When you were talking before, one of our participants asked why metastatic breast cancer sometimes change subtype. Could you talk a little bit about what we know about why that happens?
Yeah. So again, these are all like amazing questions. So thank you. So we don't fully understand that. Well, there are a couple of different things that we think about. So one is that the tumors are not just one thing. They're not homogeneous. So they probably have different clones within them, and those different clones exist. Okay. What we think could happen is that under treatment that's effective for some of them, the other ones can grow out. Sometimes what can happen as the tumor is disseminating or is spreading, that one goes here and one goes there. So some of it could be under the pressure of treatment causing that another subtype to occur. And then it could just be some of the heterogeneity of the tumor itself. But it's just that tumors aren't, they're composed of many cells, and there are different subtypes within it. And even if we say something is hormone receptor positive, not every cancer cell is hormone receptor positive within a hormone receptor positive tumor.
Great, thank you for that explanation. Someone is asking, do patients have to come off a current treatment before starting a clinical trial?
Typically, the answer is yes. There are some trials where that might not be required, but most clinical trials would require somebody to come off the treatment they're on. But typically, people are going on a clinical trial because the treatment that they are on is no longer working. So it's really a time when there would be a treatment change anyway. Now, there are some things, sometimes people have, that sometimes they stay on some form of endocrine therapy or something like that. So there are exceptions. Nothing, the one answer in medicine is that's always wrong, is always or never. Okay. So you'll take that with a grain of salt from whatever I'm saying, but I'm saying in general, people go on clinical trials typically because the treatment that they're on is no longer working, and they should then be considering another treatment.
Sure. Although certainly it's great to consider a clinical trial at any point in your treatment. Are there any benefits to doing a clinical trial at specific points in metastatic breast cancer treatment?
I think absolutely. I mean, clinical trials are, today's standard of care is based on yesterday's clinical trial. And what we're always striving to do is to do something better. And so clinical trials are also a way to get access to some of these newer drugs that are promising drugs. And so, I would say certainly whenever one is considering or needing to consider a treatment change, it's worth it to think about, is there a clinical trial? I think these days we often have fantastic, first line standard of care for many women in the first line setting. And it's definitely worth a task, but I would urge you to have a conversation with your doctor to say, well, how does this compare to standard of care? Because the standard of cares for today are about a year old or 2 years old in many of the instances. So you really want to weigh the pluses and minuses of a clinical trial. But absolutely, particularly second line, third line, fourth line, I would definitely be looking at clinical trials, and first line as well. But what you'd want to know is, how does it, what are the pluses and minuses for me, and what are the thoughts about this? But if one had, an unusual mutation or change in the tumor, then, absolutely one would want to look for a clinical trial that potentially targets that.
Right. Thank you, Dr. Isaacs. So a couple of people have this question. Could there be benefits to having chemotherapy earlier in metastatic breast cancer treatment when you're still feeling strong or when you're still feeling better? Is chemotherapy reserved for later lines because it works more broadly or because of the side effects?
So that question is one that we typically think of most in hormone receptor positive, HER2 negative breast cancer. For the time being, for triple negative or HER2 low hormone receptor negative, we're thinking about chemotherapy and potentially antibody drug conjugates, which are a version of chemotherapy, just a targeted chemotherapy. So in hormone receptor positive HER2 negative breast cancer, that is something that has really evolved over time. And I think that if you go back a while, our first thought was if we give somebody side effects and the drug is harsher, maybe it works better. And so, that was sort of the instinctive thing. And when I first started to practice medicine, which was longer ago than I'd like to admit to any of you, but when I first started to practice as an oncologist, for women with hormone receptor positive HER2 negative breast cancer, if they had any evidence the disease had spread to anything aside from bone or skin, the standard of care was to recommend chemotherapy. And that has gradually changed over time, where we've recognized that actually hormone therapy, like what we call hormone therapy, and I know it's confusing because we also have lots of names for hormone therapy, endocrine therapy, it's really estrogen blocking therapy, but it's a hard thing to say. So estrogen blocking therapy tends to be better tolerated than chemotherapy. But if you think of it, estrogen blocking therapy is targeted therapy. So drugs like tamoxifen and aromatase inhibitors, so things like Arimidex or Femara, or all of those drugs are targeted therapies. They're targeted to not let the estrogen receptor be turned on. Okay. And so there's actually a really interesting trial that was presented at San Antonio this year that looked at comparing, in a modern world, chemotherapy first or estrogen blocking therapy plus this class of drugs known as CDK4/6 inhibitors. So these drugs like Ibrance, Kisqali, all of those drugs. So it was looking at one of those drugs. And they actually found that women did better and stayed on their first line treatment for longer. They had disease under control for longer with the estrogen blocking therapy and the CDK4/6 inhibitor, as opposed to with the chemotherapy. And I think that in this country, I think that the vast majority of women with hormone receptor positive HER2 negative breast cancer as first line therapy are getting estrogen blocking therapies plus a CDK4/6 inhibitor. But there's lots of countries where they always did chemotherapy first because they thought it was more aggressive and it would work better. And this trial was a really interesting, modern day trial that showed that absolutely that wasn't true. So the answer is it's probably best to get, good targeted therapy if possible, because that's what makes most sense.
Thank you. So I'm going to ask a couple of questions about specific situations or medications. One of our participants is asking if it is okay to stop taking Herceptin if you are HER2 positive, if the drug resulted in heart damage.
So again, one has to be very individualized about that. I think, again, we did a study a number of years ago with one of my cardiology colleagues who's fantastic, who, working closely with her, we were able to show that we could safely give drugs like Herceptin to women who had some moderate decrease in their heart function if we followed them closely and worked closely with a cardiologist. And there is a specialty of cardiology that has sort of evolved with these cardio-oncologists. And so I think that I have the luxury of working with a couple of cardiologists who really have an interest in this and who specialize in this. And what it's proven to me is that clearly we can do it and women can stay on HER2 targeted therapies. Now, again, that's a graded phenomenon. It depends how low the heart function goes and what's going on. But I think, again, it speaks to the fact that it's important to work as a team. I specialize only in breast cancer. I can't treat any other types of cancer, let alone think about being a cardiologist. I need to partner with a specialist who really knows how to manage this. And I think it's something that has really disseminated into the cardiology world as well. So I think many cardiologists are aware of this, whereas before they'd say, you have to stop. But I think there are ways to manage things and to manage, for many women, some mild to moderate diminished heart function and still remain on drugs like Herceptin.
Thank you. Can you talk about the the differences among the CDK inhibitors? Are there differences between Ibrance, Kisqali, and Verzenio?
The $1 million question that we're asking ourselves. A year ago or a year and a half ago or 2 years ago, we would have said no. I mean, there are differences. They clearly have some differences because they have differences in side effects. So they have to be somewhat different drugs. I think there are some studies coming out that are suggesting that that some of them might have differential activity. That we really have to be careful as a medical profession to compare across trials. So even if trials were done in exact what looked like the similar setting, there are differences between the patients, and that's why we have to randomize in trials. So some of the randomized trials with Kisqali have shown a survival benefit, whereas they haven't shown the clearest survival benefit in some of the trials with Ibrance. There's actually also been a great deal of interest in looking at real world data in addition to standard randomized trials. So I guess the answer that I would say is yes, it's possible there are some differences between the CDK4/6 inhibitors, but I don't know that we know for sure yet that there are.
Dr. Isaacs, can you explain what real world data is?
Yeah. So real world data is this real world data is trying to look at data from regular practices to try and see how people do and try and help that inform how some drugs work and how they work in the clinical setting. Clinical trials, for any of you participating in clinical trials, many of them are quite rigid things, and they have to be rigid because in order to have a clear conclusion, they have to be done in a uniform way. Okay. But what typically happens is the people who go to clinical trials are people who have access to those clinical trials, who can get to the facility, who can do whatever, and have to meet the characteristics that they have to have relatively little in terms of other health issues. And it's a very sort of pristine world. So you always wonder how it's going to work in the real world. So electronic medical records and electronic data have made it much easier to get access to some of that. And so there are one of the issues previously to just look at, what's my clinical experience? Well, they're skewed. There are things that are there might be reasons why an individual doctor decides to give somebody one drug versus another drug. And because one of the drugs work better might have nothing to do with the drug, but because they were selecting a certain group of people to give it to. So you have to get around some of those issues in terms of the biases that you would have just at looking at clinical data. But these real world data are done within these data sets with often these companies that really have a way of culling through the electronic medical record and being able to match people relatively well in terms of different characteristics. So you're able to get a sense of how one drug is performing versus another or versus not in the setting of the standard clinic. But there still are issues with it. It's not as statistically sound in terms of data, but it can give you some good ideas about whether there are benefits to a particular drug or how it's tolerated. And so there are methods for us to be able to control for some of those things.
Okay, thank you. One of our participants is asking what it means if you're on a medication and have multiple tumors and some of them get smaller, but some of them don't.
So that could be due to a number of factors. One of the things could be that, again, that tumors are not all identical at different sites. So it's possible that at some sites the tumor is more sensitive to that particular therapy than at some of the other sites. So there is what we call heterogeneity in the tumor. The other thing is, the way that we're visualizing this on scans are not perfect things. They sometimes you can have some, what it sees as either a mass or an area within a bone that has uptake or things like that. But it doesn't necessarily say that what is there is alive and viable. So sometimes you could just have dead tissue there, but it would still look the same size on the scan. So one has to be careful interpreting these scans. And one of the areas that's hardest for us to see are like bone, because when bone heals, because there's response and the tumor is being killed and new bone is being put down, it looks exactly the same on some scans. Like on a bone scan, that will look exactly the same as the tumor growing. So one always has to be careful interpreting the scans. And then there's just a little variability, a couple of millimeters anyway. It's just, there are technical differences. So again, one needs to be cautious looking at these things and not interpreting them too strictly.
Okay, thank you. There's another question about scans, actually. Can you please touch on the topic of using CT instead of PET scans to follow progression or regression? Can you tell us more about Serena PET scans? I think that's Seriana PET scans, I'm thinking.
I'm not sure what that is, but I can tell you about PET scans and CT scans in general. CT scans give a clearer picture of the size of the tumor and sees things in much crisper detail. Okay. And CT scans obviously, only does a portion of the body, but it does it quite quickly. And that's different than an MRI, which is really focused on the technique for an MRI is very much focused on exactly the organ that it's looking at. Whereas a CT scan can quickly sort of scan from here to one's pelvis, and the radiologist can see all of the organs, the bone, the skin, everything that's within that. They get a pretty clear picture of. A PET scan, typically the standard PET scan, not the FES PET, but the standard PET scan picks up activity, it picks up glucose activity, which occurs when cells are inflamed or when there's tumor there, or when there's infection there. So a PET scan gives an idea. If there's an area that has more glucose uptake, it will be hot on PET scan, but it's not a crisp, clear picture. Okay, it's sort of an area that's hot, but it doesn't tell you exactly where it is. It's not easy to measure in size. So CTs are much more precise in terms of size, but they don't show activity. And so they can be complementary studies. And typically the studies that get done is you can do a PET scan with a diagnostic CT sometimes. So that's sort of the best of all worlds. Often what people get are CT scans and bone scans, because the bone scan looks at all of the bones everywhere and looks at activity there. And then the CT is looking at, from chest, abdomen, and pelvis area.
Thanks for explaining that. Another participant was asking whether there's a value to finding a progression once you're diagnosed with metastatic breast cancer, whether there's a value to finding a progression sooner rather than later. And in addition to scans, what other ways might a doctor be looking for a progression?
And again, that's something, that is being investigated really within clinical trials. Obviously, a very important question. The important question is, if you found that things were progressing earlier and you changed therapy, would people do better? Would they live longer? And there are some studies that are looking at that. There's certainly a lot of ongoing studies that are looking at that. There was one large study that actually looked at circulating tumor cells and changed therapy if the results didn't go down quickly enough or went up. And that study didn't show a difference, and people stopped using circulating tumor cells because of that. But that doesn't mean there won't be other techniques that come and that are helpful. But we want to make sure that making that change early actually has an impact. And the impact, we want to make sure that there are two big categories that you could think of. One, and probably the most important, is that, could it prolong survival? If you got off of a therapy that was no longer working early and got on something that worked, could that prolong survival? And then the other thing that's obviously clear on that too is, could you be spared the unnecessary toxicity of continuing on a drug that has side effects? So that is something that is being really heavily investigated in clinical trials. So I think you're hearing a bit of a theme from Sharon and from Janine and from me that, clinical trials are really trying to address a lot of the questions that you are all asking, and that are so important. And, there are new drugs within clinical trials, and then there's also embedded in many of these clinical trials is trying to also figure out who does the drug work for and who does it not work for. Are there better ways for us to figure out whether we should move more quickly or not move more quickly? Or are there things that are telling us that it's not working in this person? Because there are a lot of, for those who participate in clinical trials recently, particularly, that there are a lot of additional specimens that are being collected. And those specimens, what do I mean by that? Blood tests, biopsies, tissue, all of those things. The point of it is to, be able to figure out who's responding to this and who isn't. But also by looking at the biology, understanding who's responding and why they're responding. And maybe we could do something even better. And for the people who aren't responding, well, what's the target? And maybe we should go after that. And then also that idea of how do we follow people? And maybe what that question just asked is, we should come off sooner because the ctDNA is going up or something is happening. And we should go off sooner because it's no longer effective and we want to change to something else. So there is a tremendous amount of work in all of these clinical trials that is trying to get at exactly, I think, a lot of these questions are asking is, what's a better drug and what's a better way for me to be monitored and what should I be doing, and helping figure out what the drugs of tomorrow should be that are really can hit those targets that crop up when the tumor stops responding, so you can get more and more effective treatment.
Thank you. So we have a couple questions about some specific targets, and one person's asking whether there are drugs being developed for people whose cancers have an ESR1 mutation. Can you explain what that is and how that's being discussed?
Yeah, absolutely. So there's a lot of interest. So an ESR1 mutation is a mutation in that estrogen receptor. Okay, so remember that antenna that's sitting up there on the cell, waiting for estrogen to bind to it. And there's a mutation in that receptor that makes it active even when estrogen isn't binding to it. Okay, so it no longer needs estrogen to turn it on, it turns itself on. Okay. And so there's a lot going on research-wise to target tumors that have these ESR1 mutations. So in fact, fulvestrant, which we talked about, and these oral SERDs look like they have activity, and the oral SERDs might be even better than fulvestrant for tumors that have ESR1 mutations. So there is a lot of work that's being done. That drug that I told you that sort of broke down the estrogen receptor by other means also is looking about whether it doesn't care whether there's a change in the estrogen receptor that makes it act independently of estrogen. It's going to destroy the estrogen receptor anyway. So there is a lot that's going on looking specifically at these ESR1 mutations that seem to develop under pressure of drugs. If we talked about evolution of tumors and finding out about that, those ESR1 mutations happen in some women who are on the aromatase inhibitors, these AIs, and anastrozole, letrozole, those drugs. That's when we often see these ESR1 mutations emerging. So yes, there is a lot going on that, and there are drugs that are active, and fulvestrant is a drug that retains some activity for ESR1 mutations, and these oral SERDs also look like they have activity, and there's lots of other drugs that are following on the heels that are trying to develop activity or trying to be developed that are being looked at in patients who have ESR1 mutations in their tumor.
Thank you. And another person is asking about BRCA mutations, especially after a progression on a PARP inhibitor medication. Are there next generation PARP inhibitors, and can you tell us more about that?
So absolutely, there are next generation PARP inhibitors being developed. So there's a lot of interest again in that field and looking at other drugs that could act along that pathway. Maybe I can step back from that question and also just a broader thing, just how important it is to know whether one carries a BRCA1 or BRCA2 mutation, because we have specifically targeted therapies. And obviously, it's important for a lot of reasons. But But I've been doing this for long enough that I remember that, we started to be able to do it, but we couldn't tell anyone anything about it. We'd say, it just felt like a nasty crystal ball that you were looking in and telling somebody they had a BRCA1 or BRCA2 mutation. But now we can do things for people who are healthy and are found to carry BRCA1 or BRCA2 mutations. There are things that we can do that prevent them from getting cancer, and we show improved outcome and improved survival for people who are unaffected with cancer who have those mutations. And then for somebody who has a cancer diagnosis and has a BRCA1 or BRCA2 mutation, we have evidence for these PARP inhibitors being very active drugs in that setting and being better tolerated than our standard chemotherapies, which is what we used to do. So it's really, really important. And our current guidelines say that if anyone has HER2 negative breast cancer, and that we mean by old school HER2 negative, so includes HER2 low. So HER2 low or HER2 negative breast cancer, we should be recommending genetic testing on all of those women with metastatic breast cancer, so we can make sure whether they should be considered for treatment with a PARP inhibitor. And we also have some evidence from some trials suggesting that women who carry PALB2 mutations might also benefit from PARP inhibitors. So again, I just want to, if you know somebody or you're in that position, please talk to your healthcare provider and say, have I had genetic testing and do we know? Because we have drugs that are specific for people who carry mutations.
Thanks, Dr. Isaacs. Our next question is from someone with metastatic TNBC, triple negative breast cancer, and whose cancers have responded well to treatment and is seeking a mastectomy, but is having difficulty getting it. Can you comment about what the standard of care is with using surgery in metastatic breast cancer, and how you can get more information if you're seeking a mastectomy?
I would go to an academic medical center, okay, and get a second opinion about this. So the question is for somebody who has metastatic breast cancer, and this typically, the situation where we be thinking of this question within this context is if somebody at the time that they were diagnosed with breast cancer, they had metastatic disease. And the question is, should they have surgery on the breast, which is typically what we do for localized breast cancer? Does that impact outcome? And should somebody have that if they have metastatic disease? And, that again is a very individual discussion. So let me just stress that it's hard to say on an individual basis. There are certain subtypes and certain situations where we think of it, but right now our literature suggests that for the majority of women who are diagnosed with metastatic breast cancer, we don't have evidence that doing a mastectomy or doing local therapy prolongs survival. It could improve quality of life in some cases. It could be used for symptom control. Now, again, that is not universal, okay? So I really want to make that very clear. If we have women who are doing well for a long time on therapy or have, very limited amount of metastatic disease and have a tumor that's HER2 positive, where we know we can often get a very long response, we do think of it and we do individualize things. So again, I want to share with you what the literature has now told us, based on some randomized trials, is that there was and again, the studies are limited because it was hard to accrue to the studies. But that is something that one would consider on an individual basis. And the reason for that is not just, because somebody, doesn't want to take somebody to the OR, but there are risks with surgery. And what we're always trying to do is to make sure that if we're recommending an intervention, that there's a good reason for it and that we're not exposing somebody to unnecessary risks. But I would say if somebody is thinking of that, understand with their healthcare provider why they're not recommending it. Please explain it to me. And if you're not satisfied with that explanation, go get a second opinion about it.
Thank you. Well, it's hard to believe, but the hour has really flown by. And so I'm going to ask our last question and just give you a moment for any closing thoughts. One of our participants is asking, what questions should we be asking of our oncologists to understand some of these really recent developments? How can you get more information directly from your doctor? So that people can understand the latest therapies and be able to discuss them better with their doctors?
I think, I think a question like asking, do any of the latest findings apply to me? How does that, should I be thinking about some of these new drugs that I'm thinking about? And I think often one word of caution is, people will, institutions, organizations will post very early research, and we have to be careful about applying very early research to the clinic. But there's so much coming out all the time from well-done trials that are really changing things. You've heard how hard it is for me to try to explain all of this to you, and you know what it's like in a busy clinic setting. It's not like your doctor can stop and give you a treatise about everything new that's going on. But I think a question like, I'm seeing all these exciting new things coming out. What does any of that apply to me? Does it apply to me now? Would you think about it down the line? What should I be thinking about? Should I be thinking about a clinical trial? Are there new developments that are impacting how you view how you're treating me?
Thanks for answering that question. Before I make closing remarks, is there anything more that you'd like to share with our community this evening?
I think just the hope of all the advances that we're making. It's dizzying in some ways, which is fantastic. Okay, it's fantastic because we have new treatments, we have new effective treatments. They are changing the landscape, and there are a ton more coming behind it. I think one of the things that I've seen over the last number of years is how industry has gotten much more interested in just small niches and small targets. And, before that, they only used to focus on, big things, the things that were the most common. But I think what we've recognized is we have to think of cancer in a more individual way, and trying to have a treatment that works for one person won't necessarily work for the other. But it's really, I look at the trainees, I work at an academic institution. I look at the fellows who, are just about to come out of their training. And I think you are going to be in such a different world than I was. And your world is going to change over and over again. And that's really felt like things have been changing quickly over the past 5 to 10 years, and are going to evolve. So there are new treatments coming down the pike every moment.
Thank you so much, Dr. Isaacs, and thanks for covering so much tonight.